Honorable colleagues, friends, associates, it's an honor and a pleasure to be part of this highly reputable meeting organized by the WHO on uniting together against mycetoma, innovative solutions, and urgent actions. My name is Professor Fahal. I am a professor of surgery at the University of Khartoum, the Mycetoma Research Center. I would like to declare there is no conflict of interest in these presentations. Photos, images were taken after informed consent or from open sources. I would like to share you our journey with the mycetoma at the Mycetoma Research Center. In the coming few minutes, I'm going to discuss with you the mycetoma as a neglected medical and health problem, and to share with you our experience at the Mycetoma Research Center in dealing with mycetoma and mycetoma affected communities. Furthermore, I would like to tell you about the impact of the war on the Mycetoma Research Center and the patient management on our research. Then, eventually, I'm going to take with you some take-home messages. Ladies and gentlemen, the main objective of this presentation is to share with you experience, exchange knowledge on mycetoma as seen at the Mycetoma Research Center. Secondly, I would like to share with you some of the challenges and the opportunities we face in dealing with these poorly recognized patients. And then lastly, I would like to share with you what we were doing at the Mycetoma Research Center. Ladies and gentlemen, the Mycetoma Research Center is the only WHO collaborating center on mycetoma and skin entities, designated in 2015 as a collaborating center. For those who may not be able to stay to the end of the presentation, I would like to conclude my presentation by saying that mycetoma is a scar on the human conscience, and our job is to heal it, as it is one of the non-glorious diseases. Again, I would like to conclude by saying that in the area of the patient care and the management, the Mycetoma Research Center had managed to manage more than 12,000 patients with mycetoma from Sudan and from overseas. We conducted the first ever double-blind clinical trial on mycetoma by using new techniques to establish the diagnosis of mycetoma, and we have 2 satellite centers in areas where mycetoma is endemic in Sudan, mainly in the White Nile and in Sinai State. Also, we established site, and I'm going to talk about site in a minute. And again, we train many of the medical and health cadre at the affected areas. In the area of research and development, the Mycetoma Research Center had trained more than 50 postgraduate students, published more than 320 articles in highly reputable journals. We have a lot of international collaboration, research projects, and research grants, and we established Al Hassan Center for Neglected Tropical Diseases clinical trial, one of its kind in the region, and we are now using a lot of AI techniques for management of patients, diagnosis, and training of our staff. In the area of community engagement, the center had organized good number of community engagement initiatives in endemic areas. We have a media center that produce a good number of videos, material for advocacy and awareness. Furthermore, we organized many campaigns in endemic areas for prosthesis, shoes, and environmental condition improvement. We are engaged with many fine artists in the country, again for awareness and advocacy for mycetoma, and we established the Mycetoma Friend Association, and we have many ambassadors working with the center to execute its function, objectives, and mission. Ladies and gentlemen, mycetoma, it is a chronic disabling disease characterized by massive deformities, destruction, leading to loss of life and loss of function. WHO in 2016 designated mycetoma as a neglected tropical disease. In fact, it is a unique neglected tropical disease, and I will show you in a minute why it is a unique neglected tropical disease. It is a devastating medical dilemma, as you can see in this patient with intracranial mycetoma. Mycetoma, in fact, is a shattering medical problem and a dilemma, and you can see how massive the mycetoma affecting the foot of this patient. It is a serious problem. This chap had an actinomycetoma, amenable to medical treatment because he presented late. He came with a massive disease, deformities, ended in an amputation. And you can see the misery that patient can develop in his life. It is a disfiguring medical problem, and you can see how massive the mycetoma affecting the knee of this patient. No doubt, it is a disabling disease, and it can be an aggressive problem, just like in this patient with actinomycetoma, which is a relatively benign condition. He had a foot mycetoma, for which he had a blown knee amputation. He developed a recurrence, and he developed a recurrence on top of the amputation site that has spread into the abdominal cavity, affecting his urinary bladder. Mycetoma is disfiguring problem, and you can see how massive is the disfiguring of this patient and the difficulty in dealing with her normal life activities. No doubt, mycetoma, it is a disfiguring, mutilating medical, health, and social problem. Mycetoma has atypical characteristics. It affects the poorest of the poor in poor remote communities, affecting those who dealing with the soil, with the traditional farming and other activities related to the soil, commonly seen in this group of people. Mycetoma enjoys all the neglected tropical diseases characteristics. Social impacts, no social life, no work, and no education. In fact, it is a social stigma. Typically, mycetoma is seen among farmers, workers, those who are dealing with the soil, with the soil pricks, with minor injuries, and that's an important cause for the infection through inoculation into the skin and the subcutaneous tissue. Sadly, 1/3 of our patients are children. I can imagine the misery and the difficulty among these patients. And I can imagine a young child like this with intracranial mycetoma, and you can imagine how will be his life with the mycetoma. Many of the patients are students, and it is common among this group because they are dealing with the soil, they're playing in the soil, and that's an important cause for trauma and the inoculation of the infection. It affects young adults with a high morbidity for quite a long time and may continue for life. Almost 30% of our patients are children. The gender ratio, it is 3:1 at the clinic, but at the village, it is almost 1:1. It's interesting to note that during pregnancy, the mycetoma become more aggressive, more destructive, more sinuses, and that may be due to decrease of the immune responses during the pregnancy state. Our patients are of low socioeconomic status, and you can see these patients coming to the clinic with this vehicle. The low socioeconomic status of our patients and the low health education level led them to seek local traditional treatment that can delay their presentation and that can affect their management and hence the poor management outcome. There are two types of mycetoma, the fungal type caused by fungi and the actinomycetoma caused by bacteria. And almost the two types of mycetoma had the same clinical presentation, and the cause is unknown. The mycetoma type is caused by fungi, and more than 50 microorganisms were incriminated in causing this mycetoma. And the Madurella species are the commonest. For actinomycetoma, Streptomyces somaliensis, Actinomadura maduri, and Actinomadura pelletieri and nocardia are the common causes. It is interesting to know that at the Mycetoma Center, we managed to isolate 10 new novel mycetoma causative agents reported for the first time. The first one was Madurella fahali, and then a lot of other organisms were reported causing mycetoma in Sudan for the first time. I have to say, we are facing a lot of challenges, difficulties, and constraints in dealing with mycetoma patients. There is an urgent need for effective drug. There is urgent need for good diagnostic tests to diagnose mycetoma at an early stage and at the level of the villages. Furthermore, we need to have a point-of-care test for the diagnosis of mycetoma, and currently there is no preventive or control measurement for mycetoma. As there is no point-of-care test, and as these patients are of low socioeconomic status and are of low health education level, they present late with advanced disease, and then they develop the poor management outcomes. To address all these issues, the Mycetoma Research Center at the University of Khartoum was established in 1991 with a clear vision, objectives, that is to conduct a cutting-edge research on the mycetoma epidemiology, to contribute on the designing of new diagnostic tests for the mycetoma diagnosis, and then to offer the patients the best evidence-based management and treatment. Furthermore, then to have an insight about the mycetoma, trying to find means and measurement to reduce the burden of mycetoma globally, and then to rehab the affected patients and communities. Regarding the epidemiology of mycetoma, the Mycetoma Center has organized many field surveys activities. We surveyed a lot of villages, regions in Sudan. We conducted house-to-house surveys to study the epidemiology of mycetoma among the affected groups, and we trained many of the community members for early detection of mycetoma and referring them to centers for management and treatment. During these activities, we used our own data collection device, and that is the CABI, computer-assisted patient identifier, looking for the characteristics of the susceptible patients, taking photos of the lesions and the coordinate of the location where the mycetoma patients there. Through these surveys, we managed to map the mycetoma in Sudan and to spot the areas they need attention and care. Also, during these surveys, we managed to establish our own SOPs, procedure to conduct a proper epidemiological surveys, and we managed to determine the demographic factors, the socioeconomic characteristics of the affected or susceptible patients, and all the time health education sessions were there. We had the opportunity to look into the environmental factors that may cause mycetoma, and we studied that in detail: the temperature, humidity, the soil, and other environmental factors. and we managed to identify organisms in the soil and in the environment for the first time. As I mentioned, health education is an important issue for the Mycetoma Research Center. This is one of the activities in the field, one of the affected villages, and we have the pleasure to have His Excellency the Minister of Health in Sennar in one of these sessions. We visited hospitals, schools, markets, advocating for early detection of mycetoma and treatment. And this is one of the sessions of the health education in one of the villages. And again, you can see this is one of the campaign for donating shoes and health education for children, pupils, and students in schools. We published a good number of articles, work on the epidemiology of mycetoma based on our experience from the Mycetoma Research Center. Ladies and gentlemen, the diagnosis of mycetoma is not easy. A lot of challenges, a lot of difficulties, and we need to have a combination of test tools and techniques to establish the diagnosis of mycetoma, starting from the culture, from the microscopy, and for the PCR, and from the imaging, and all that is needed to establish the diagnosis of mycetoma. There's a lot of gaps in the knowledge of mycetoma diagnostics. The available diagnostic tools are of low sensitivity and low specificity. They are invasive, they are expensive, and they are not available, and if available, may not be accessible by many of the patients. The Mycetoma Center used for the first time new techniques to establish the diagnosis of mycetoma. The ultrasound diagnosis was established for the first time at the Mycetoma Center, and nowadays we are using ultrasound-guided cytology to increase the yield of the cytological smears and the diagnosis improvement. The Mycetoma Center was the first to use the molecular techniques to identify the EU mycetoma causative organisms, and again that had a lot of impact on the diagnosis of mycetoma globally. We are working with different groups, research centers, universities to develop a point-of-care diagnostic test for mycetoma that can be easily used, field-friendly, and can use at the level of the affected villages. We are working through the Rufti Foundation project with Erasmus Medical Center, with Senegal, with Newcastle, and Sydney University. We are working through EMIT in Japan project with 4 Japanese universities, again to find a suitable point-of-care test for mycetoma. And furthermore, through a GHIT fund in Japan, we have a group of scientists, colleagues, working to find a point-of-care test for mycetoma patients. Our aim is to find a field-friendly, easy-to-use molecular test at the level of the villages, so as to reduce the burden on the patients to go all the way for diagnosis and for treatment in big centers. And we published many articles on the diagnosis of mycetoma. Regarding the patient management, as I mentioned, the Mycetoma Center managed to manage more than 12,000 patients at the center in Khartoum or at the villages through our medical and health divisions and inside our satellite centers. The Mycetoma Center conducted the first ever double-blind clinical study using a pre-purposed drug, pozorovoconazole, with a very effective outcome, and that was published at the Lancet Infectious Diseases. Surgical treatment for EU mycetoma can be difficult and can be tedious, and this is one of the patients with a massive mycetoma of the chest wall, abdomen, and the back. This patient underwent a surgical excision after a medical treatment, and this is the outcome. She is much satisfactory for us. The treatment of mycetoma, specifically the mycetoma, may be very tedious as I mentioned. As you can see in this patient, with a very massive gluteal perineal scrotal mycetoma. After recurrence, this patient was seen at the Mycetoma Research Center, underwent more than 30 surgical operations, and he stayed in the ward for almost 3 years with a satisfactory outcome. However, after discharge, he disappeared and he developed a massive recurrence after that. I have to say that the outcome of many of the mycetoma patients, specifically the mycetoma patient, is not satisfactory, as in this young lady ended in amputation or a massive deformity and amputation of this patient. Sadly, there is no in the pipelines any new drug for mycetoma patients. For the actinomycetoma, it is much better management plan treated with a combination of antibiotics, and you can see in this patient with a very massive mycetoma of the foot with a bone destruction and soft tissue involvement. With the proper diagnosis and the treatment, she recovered in few weeks' time. This is another example of mycetoma of the head and neck that responded well for a while to the antibiotics. Is it the same patient before treatment? Is it during treatment? And then she stopped the treatment and she developed massive actinomycetoma recurrence after that. Right now, with many groups and colleagues, we are now looking for other 3-purpose drug for mycetoma patients, and we're looking for new molecules. And many of my young colleagues are utilizing artificial intelligence tools and techniques to find new molecules for mycetoma. We published more than 320 articles in mycetoma covering different aspects of the disease and its effect on the patient, the communities, and the health system in general. Currently, there is no control program for mycetoma. Hence, we organized many field activities and surveys for early case detection, for the diagnosis of these patients, and to start treatment as soon as possible, and health education sessions all the time is there, and to train the staff in the local affected communities. This is our center at Odonsa village, where we have a satellite center. We do most of our work in there. We see patients, we treat them, organize health education sessions, and have other activities there. We always organized medical and health missions to the affected endemic villages in Sudan, trying to find early cases and to start the treatment. In these missions, we conduct a lot of ultrasound examination, trying to confirm the diagnosis of mycetoma. This is one of my colleagues, midnight, examining a patient with a mobile ultrasound using the mobile torch, collecting samples to confirm the diagnosis. And the missions are not very easy, a lot of hurdle, a lot of challenges, a lot of difficulties during these activities. But eventually, we manage and we succeed to manage and to treat 1,000 patients surgically in these areas, and to conduct a training for our young colleagues at the rural areas and the rural hospital there. Also, we conducted 1,500 ultrasound examination using a mobile ultrasound machines. Children and young adults are always part of our activities so as to reduce the burden on them and their families, and not to travel and not to disturb the mechanism of life for the families. These activities had reduced the number of patients coming with a massive mycetoma. Hence, we are seeing patients with early cases, proper diagnosis, proper treatment, and proper good outcome. This is a typical village of mycetoma endemic area. The animals in direct contact with the human in direct contact with the soil, the animal dung, with the dirt, with a thorn, with a sharp object, and hence high incidence of mycetoma. To address this, we managed to design and construct more than 70 healthy animal cage out of the villages, trying to reduce the contact between the human and the soil and the organisms. Mycetoma is characterized by disability, by psychosocial impact, and by social stigma. And you can see how difficult this member of the family dealing with his brother take him all the time, and you can see how miserable the situation is. In mycetoma, amputation is an important barrier for having a proper treatment. Many of the patients, they don't come because of the fear of amputation. Amputation put the patient at the end of his life, end of the track, and end of his path. Amputation is an important cause for stigma, for poverty, and for literacy. And amputation may be as massive as this. This is a total disarticulation of the whole lower limb in a patient with advanced mycetoma in the gluteal region. Amputation in some villages where mycetoma is endemic runs in the family. These are 4 members of one family with amputation due to mycetoma disease. No doubt, mycetoma disturbs the mechanism of life of the affected families and patients, and that has impact on different members of the family. In endemic areas, patients with amputations use local-made, badly constructed, difficult to use, heavy prostheses, and that had again affected the quality of the life of the affected patients. To address this issue, we contacted one of the pioneers incubators in Sudan to design a prosthesis for these patients. And this is one of the examples of the prosthesis used for one of the amputee. Furthermore, we moved this mobile workshop to one of the villages where mycetoma is endemic, and through this workshop, we managed to produce more than 160 artificial limbs for the affected patients. And this is a group of ladies after having the new prosthesis and change of lifestyle. Once again, I would like to say that mycetoma is characterized by disability. It has many psychosocial impact and social stigma. To address this, the Mycetoma Center has produced, designed, and established the Mycetoma Vocational Training and Entrepreneurship for Mycetoma Patients site.
The center found that there is a need to provide social and economic support to patients to help them after receiving treatment. Thus, we established the Mycetoma Vocational and Entrepreneurship Training Center, SIDE. SIDE Center provides training to acquire knowledge in the fields of sewing, carpentry, horticulture, leatherworks, pottery, foods, and others.
We established the Mycetoma Media Center, trying to help in producing high-quality material for advocacy and awareness on mycetoma. And this is one of the examples of this. The Media Center has established We Are With You advocacy group. And this is a group of top celebrities, musicians, artists, and comedians working together with the Mycetoma Center for advocacy and awareness on mycetoma. And this is one of the activities of this group. Mycetoma has many ambassadors working together with the center, trying to execute the center vision, objectives, and activities. And we had a lot of interaction between them to improve the quality of the life of the affected patients. We have more than 23 international collaborating body, centers, universities on research, on field activities, as well as the community engagement activities around the globe. We are integrating now the mycetoma with other skin entities in line with the WHO roadmap plan. The mycetoma was designated by WHO in 2016 as an related tropical disease. Still, there is unmet promise to improve the quality of the life of the affected patients, to improve the research quality, and to improve the community involvement activities. As you can see, the Mycetoma Research Center is dealing with a unique disease, with a unique patients, a unique problems, and hence we need to have a unique solution for these patients. And we were working on that. Suddenly, on the 15th of April 2023, a conflict of the Sudan started, and that had impacted our mycetoma journey and the story and our management of mycetoma patients. The war has affected the life of the human being, the infrastructures, and our activities as well. And this is the Mycetoma Center after the war. When the war started, we moved to Jazeera, where we established a center at Mederi Teaching Hospital. And then the Jazeera was invaded, and then we moved to Sinja, where we established another clinic there dealing with mycetoma patients. When Sinja was invaded, we moved to Kassala, where we established our Kassala mycetoma clinic, and we are dealing with most of our patients there right now at the clinic there. After the war, we started immediately to plan what to do, how we can rectify our endemic infrastructure, how we can maintain the staff development activities, and how we can mitigate the losses in our biobank, and how we can restore our research, development, and international collaboration, and then how we can raise funds to deal with these problems, and how we can provide better care for our patients. Despite of all difficulties, we continue to work and to work hard with the activities of all our staff. And recently we published an article in Nature Communication. Our junior staff are continuing working for their master degrees, PhDs in different universities and in different centers to get their qualification. Once again, I would like to express my sincere thanks and gratitude to His Excellency, Director General of WHO, Dr. Tadros, and Dr. Ahmed Al-Mandari, the past EMRO Director, for visiting the center and for supporting us before and after the war. Together, we are sure we can re-establish the Mycetoma Center and can work together to execute our objectives, mission, and our vision. And I would like to thank you very much for your kind attention and for being part of this highly reputable meeting. Thank you very much, and this is my contact.